Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. We have a really fun, hopefully interesting and strange and wandering and hopefully really fascinating show today. I'm here with two guests, Elvina Hewitt and Mena Ramos, and I'm going to let them introduce themselves in a minute. I'm just going to say one thing about it, which is that all three people on this episode we're all Brown class of 2005. All of us spent time working in emergency departments in one form or another. And all of us now do things that are wild and interesting and have vaguely to do with AI and stuff. And I'm going to leave that sort of thread out there. It's been wonderful to reconnect with these two lately, and I'm excited to have them on the show. Y'all welcome and thanks for coming. Okay, one of you has to say something.
Okay, awesome.
Okay. All right, we're gonna leave that in. We won't edit that part out. Okay, would you all please introduce yourself so folks know a little bit about your background and just give us a brief overview of the arc of stuff. And I think what we'll do for this is we'll talk a bit about each of our journeys and then talk about the common threads. Somewhere underneath this for me is a big question of, is there a reason that we had somewhat parallel paths, and what does that teach us about the systems that we're operating in? But Mena, maybe we'll start with you. Can you give us just a brief overview of who you are and what you do now, and then a little bit about how you got there?
Sure. Thanks so much for having us on this podcast, Dan. So my name is Mena Ramos. I'm a family physician by training, social entrepreneur by passion. I co-founded and now the co-CEO of Global Ultrasound Institute, a medical education and training platform and community that's trained over 20,000 clinicians globally in point-of-care ultrasound. I'm also a philosopher and a musician. I really strongly believe that showing up as a whole human being is an important part of the work, especially in entrepreneurship.
Wow, awesome. That's a really strong intro. Okay. So hi, everyone. My name is Elvina Hewitt. My background is actually in nursing. So I've only really worked in ER nursing. I've done that for about 14 years and then spent the last almost 10 years focusing on health tech startups and really thinking about how we can really reimagine how we do healthcare in a very tightly regulated space. I've been spending the past couple years focused on aging care. I've done some work in hybrid care, really focusing on rural health. I have recently ventured into the venture studio space and understanding how that works, looking at how we can reimagine mental health. And most recently, I've been really kind of consulting with some startups, trying to help them do better storytelling, kind of help them figure out what problems to solve that really feel like they're impactful in the healthcare space while also not creating more work for clinicians. I feel like that's often something that's overlooked. And forging my own path, I'm trying to figure out if I'm going to open an adult day program, which I'm happy to chat about. I think supporting older adults is a true passion of mine, and it's time for me to dig into it. That's just a little bit about me, and happy to answer everything and anything.
Cool. So let's start a bit with how we got into this. I'm always curious about how people get into emergency medicine. If anything, of the three of us, I might have, actually, I don't know. I was going to say I might have the most logical path, but I actually don't know if that's true at all. Perhaps the most standard path, but again, I'm not sure. So when did you all first get interested in the emergency department? What brought you into it? Did you know you were going to do that back when we were all at Brown together? And what did that arc look like for you? And by the way, I'm gonna start by retracting my statement, which is I don't think I have the most logical or ordinary path into it. I think things just look logical from inside your own head. So let's pull that back and then go back to the question, which is what got you all into emergency medicine?
Well, I can start. So when I was at Brown, I was pre-med and thought I was going to go the med school route and decided not to because I was doing research with a physician who was an amazing pediatric oncologist. And she actually seemed really frustrated with the medical space at the time. And just that it was this landscape that was changing from kind of this, I think it was very much initially, or at least what we intended to be, which is you're going to always do right for your patient, right? And she was seeing this sea of change. And I've actually spoke to a couple of physicians back then where they were very frustrated with the current changing of the tides of how healthcare was going, which was like, not necessarily being dictated by what you should be doing for your patient, but what insurance they had, right? Or like how they could pay for their care. That definitely gave me some pause. I randomly took a left turn into IT consulting for a year, which hated very much. And then I met a woman who was a retired teacher who then decided to become an LVN in her retirement. It was amazing. The way we talked about it was what I really wanted to do was care for patients for extended periods of time. So I could see the full trajectory, or as much as I could, of their care and kind of the impact that I was having on them. So I went down the rabbit hole of nursing school. I was really attracted to emergency care. Just, I think the variety was what I really liked. My first role was actually on a trauma step-down unit at SF General, and then really wanted to, always knew that was where I was going to end up, was in the ER, and it was just kind of like how I was going to get in there, and kind of loved it ever since, I guess, until I left. I think I've always wanted to do it. I don't know. I think there was just something about the urgency and the chaos that I'm very much attracted to.
So,
yeah.
So starting at Brown in pre-med and then sticking with a healthcare arc and reevaluating what medicine and what the role of a doctor in the medical system really is, and finding that, hey, this other thing, nursing, really fits me better than what I was exposed to begin with. Is that okay?
Yeah.
Mena, does that match your path at all?
I think I had a bit of a more circuitous path to working in emergency medicine. I was pre-med at Brown, but I was in the closet pre-med in the sense that I love the idea of medicine as a profession that gives service to communities and the world, that has a positive, in my mind, a positive impact on society. Yet there was something about the culture of pre-med, I think that's in not just at Brown specifically, but this competitive nature that seemed somewhat counter to what I imagined the profession to be, which is, hey, we're all in this together in greater service of humanity as a social and public good. So I didn't throw away the idea of going to medical school. I took pre-med classes, but I wandered and took lots of classes outside of pre-med. So that's why I was in the closet as far as pre-med goes. And I learned about this very interesting program to study medicine in a very different environment, which was in Cuba. And I read about the program and I was really intrigued. So I went to go see the medical school dean at the time, who was like, that's a terrible idea. And immediately I was intrigued, because there are not many moments, at least in my experience at Brown, where you have an idea and it's a terrible idea.
That's fair. Yeah. That's a real signal. Yeah.
Yeah. I was like, oh, that's interesting. And I was feeling like that there was a reaction in that moment. And I was curious, like, where is that coming from? So I ended up spending 6 years studying medicine in Cuba, which was one of the most incredible experiences. It was very challenging. I learned a lot. And when I decided to go into residency, I did a residency in family medicine. It just seemed to really align with the breadth of my interests. And as far as a culture, there was the people that I met and talked to in family medicine seemed very service to the community oriented first. So I did a residency in family medicine at a small county hospital about an hour outside of San Francisco. And I strongly feel that the people that you're around largely shape how you end up your path, mentorship, the people that you mentor, your community. And so in residency, I had a couple of wonderful mentors who worked in emergency medicine. They were also very much passionate about point of care ultrasound, which led me to working in that safety net hospital and emergency room after residency and doing a global health fellowship. And so it was really an alignment of several different interests, service, and also kind of curiosity. That I think the pace and nature of emergency medicine is unpredictable, and it requires showing up every day and being ready in the unreadiness, in the unpredictability, and being comfortable in that, and almost embracing the discomfort and finding the steadiness in the storm. And I think there's something I wasn't totally cognizant about, but now looking at my arc and decisions since then, I'm like, oh, interesting. It's a through line, even through entrepreneurial work and work with AI, et cetera, that there has to be an openness to the unknowing.
Yeah, that's so interesting because I think that feeling of that both of y'all are describing that I certainly felt as well, which is showing up in some of these classes, being like, look, I want to make a difference. I think health is important. I think the role that I've traditionally been taught that a doctor or that medicine plays in a community is really crucial. And then looking at the reality day to day of what people are going through and what they're doing and the folks around you and the mismatch of that in some sense, right? What you're describing, Mena, about being like, I didn't love the culture of pre-med, or Elvina being like, I don't even know if this is the right role that I'm stepping into. I totally felt that, right? I wanted to help people, but all the pre-med people were jerks, present company excluded, obviously. But I was like, this is terrible. I don't want any piece of this. The people that seem to be really focused on solving problems that really cared were like, I found them in the engineering school or studying physics or the other stuff. So I was like, oh, I'm gonna go do that, right? And drifted laterally into medicine from that space. But what's fascinating to me about that is the step of, I want to help, I want to do something that matters. There's this weird fuzzy culture around it that makes that direction really challenging and hard. So I'm going to go do this instead. Okay, now I do that. And then somewhere in that sidestep, which is not a back step, right? It's just choosing a different path towards what you want to be doing. All of us somehow ended up with this sense of emergency is a very unique and very, I don't know, darkly wonderful part of healthcare, right? It has this gravity to it that is very different that a lot of people don't get trapped in, right? Or don't get drawn into, and they go off and do something else. And I wonder why that is. I wonder if that's related to the way that we entered into the system, although we took all of us different paths to get into it. And I wonder what it is that made that sticky for us. It sounds like all three of us spent time in county-style facilities that were devoted to serving the underserved, right? That certainly was true for Boston Medical, where I did all of my training, right? It was the safety net hospital. And I'm fairly ignorant, Mena, of the Cuban medical system, so I genuinely don't know much about what your training would be like there. But I would imagine that being exposed to the realities that our patients face drove us. But I don't know, what do you all think of as you hear that? 3 different opening paths, and then this weird convergence back into emergency.
Yeah. So one of the things I've been thinking about since Mena was talking earlier was really around, I think what's attractive about emergency medicine is not necessarily the rules or the guidelines, but the fact that you kind of have to work in this gray zone, right? It's never, the guidelines are there, obviously, to keep everyone safe, but you're always functioning in this in between because in some ways you kind of have to push it to help someone survive. Or every patient has a different story and a different life consequence. And you don't, just because you can discharge someone to this facility in this way, the next person walks in the door that might have the same diagnosis is the complete opposite, right? These guidelines exist, but they don't actually work necessarily all the time, right? And I think maybe that's the frustration around emergency medicine too, is that you really see the realities of how people live and the limitations of how the system's set up for them, right? And I think for all of us, having worked in city and county, we really see the entire spectrum of life circumstance and what is achievable and what's not.
Yeah, I think an emergency room in many ways is the true safety net of society. It comes to the initial point of contact for care for many people. And there is I think almost a lack of a filter or screen from what you may see and experience in an emergency room setting, and the society and community as a whole, all of it, and social determinants of health, biopsychosocial determinants of health. There isn't the filter from the space of an emergency room and what leads to why someone may end up in emergency room, that filter is so much more porous than in many other medical settings where you have to make an appointment. You need to, I think there's that through line of wanting to be in service, and for better or for worse, the emergency room has become almost that for many people in many communities that initial point of contact, even though it wasn't designed to be that. I think that is one of the through line, and also nobody goes to the emergency room on a good day. It's right, and there is a degree of vulnerability that training on, and whether it's someone who's going there themselves or accompanying someone to end up in an emergency room for one reason or another, any time of the day, there is a vulnerability, and having the grace to show up and be present and hold that vulnerability is not something that I think any of us take lightly. We all recognize that is one of the work of working in an emergency.
Yeah, absolutely. It's a privilege, right? It's really it's a privilege that someone is able to trust you with their most vulnerable moment, and it's a responsibility of how you react and respond in that moment, right? And so I do think that there is a special experience that you get there, both as a provider and ideally as the patient and our family caregiver. And the hope is that we all remember that when you are functioning in that space, these people really are at their most vulnerable, whether or not it might seem like an emergency to you. It's an emergency to them, and how you respond is going to completely change the trajectory of their experience.
I think there's a sense when you're in there that you're part of this chain of humans that are trying to stand up between people and suffering. When it's your time, when it's on shift, it's your time to hold the line for that moment. And I don't know that's something I would have understood when we all met back in college. I think I would have understood it in theory and been like, yeah, that sounds cool and noble and I like it. But to understand the visceral nature of what that means, to be on at night when everyone else is asleep, trying to hold the line a little bit, is really deep. And I guess it's worth for a second inverting that question. So why do people go through medicine and not end up in the emergency department? Because there's alternate versions of us in other universes that all studied together and did all the same stuff. And we're all three sitting here and we're all pediatricians or oncologists or OB-GYNs or whatever it is, that because all parts of medicine that are totally noble and wonderful. And I guess I'm curious about this again from the sense of, all right, let me take a step back and frame this. The more time I spend in medicine, the more time I think about systems, right? And the systems that nudge people towards or away from different things, right? From a complexity standpoint, attractor states or whatever you want to talk about it. So it strikes me that we're three people that had, for at least part of our life, a very similar set of experiences. Now, Brown's a very wild, different place. So I would imagine that we all had different paths through it. Although there was a time that Mena kicked me in the face, which we're not going to talk about on this podcast. But even within that sort of variability, we all had a period of time at the same age, roughly in the same years, where we were together and occupied space and time that were similar. So is that related to us being in emergency medicine? Is that a system that nudges us toward it? Are there unique factors in there? Or is it completely by chance that the three of us are sitting here today? And what does that teach us about medicine as a system? I don't know, take that question or take the other one about why do people go through and not be an emergency, and I don't know, run with it.
I will say, Dan, that the reason why we're all on this podcast today is not because we all happen to, at one point in our careers,
That's true.
emergency medicine.
Yeah, that's true.
We all, in many ways, reconnected because of work that involves, sure, it's adjacent to our work in medicine. It involves technology, thinking about AI, philosophy, entrepreneurship, intersections of multiple different fields that impact healthcare and well-being. And so I know this is an emergency medicine
No, go
podcast.
broadly. Yeah.
And it's part of the through line. And I think that experience very much informs the work that we do. But I think why we're here and what brought us all back together is that we're taking our experiences and learnings from emergency medicine and expanding it, taking a much more expansive approach. Because the reason why I ended up leaving working clinically in emergency medicine was because I wanted to, I think the burning kind of curiosity and desire to be part of solutions that could impact patients and communities at an even greater scale, or what happens before they end up people end up in the emergency room, what ends up afterwards, and can some of the work that you do positively impact that continuum of care. I'll pause there, but I think the through line is truly just curiosity, joy, and curiosity, a centeredness around service as meaningful work. And yeah,
I'm trying to think of how to answer either of your questions. I would say that if I try to stay PC here, but I think that for different
You don't
specialties,
have to.
they attract very specific personalities. And I don't know if it's the same thing. I actually would say it's the same thing for physicians, but for nurses, for sure, right? You know, when you meet an ER nurse versus an ICU, there are like jokes about it all over the internet, right? But they're pretty true, right? They run very true. You know what kind of nurse, what kind of person would fit into which specialty, because there is something about the personality that makes you thrive, right? It's the same thing across any job, right? You think about what are your skills? What are you actually good at? And if you find a job that fits that, then you're going to thrive. Because I think for me, having managed the ER and also hired and let go some people that entered our training program, it's very clear to see what kind of personalities are able to handle the unknown, right? The chaos, you never know what's coming in the next door. And I think OBGYN is very similar in some ways, emergency medicine, where you really don't know what's coming in your door for the most part. So I would say I think there's a mix of enjoying the chaos. Typically people are like adrenaline junkies. Most of the first responders I have met, I'm married to firemen, there's something to that of like just having that. There's an addictive quality to that, I think, of like just being on the ready and being able to really help save someone, and like just seeing that impact happen just instantly is pretty incredible. So I don't know. I think that there's just something to the type of people that enter into emergency medicine and the people that don't. I actually think that I could probably tie this in some ways back to Brown. The reason we all chose Brown is that it was this amazing education that supported this. Just go find your interest, right? But you might have to follow these few things to get a major to graduate, but really we want you guys to explore. That was what I thought was like the beauty of the program. Take the classes you want and like just see what, you never know what's going to spark your interest, right? And so I think that in some way it's very similar in emergency medicine, which is like, you can't put us in a box, dude. Like you just can't do it. And I think that's part of the frustrations of when you're working inside a health system of like, you're expected to squeeze inside this box and just do the thing. When in reality, we all know that box actually is more harmful than good in some ways when you're really trying to help someone. And so to me, like, maybe that's it. And that's also why the three of us are sitting here having this conversation is we are all just kind of, I don't want to be in your box and I want to break it and I want to recreate it into this weird funky shape because it's going to be better.
One of the groups that I spend a lot of time working with, the Mission Critical Team Institute, talks about aircraft carriers and fighter jets, right? So aircraft carriers, really big, classic high reliability organization systems. Everything has to be precise and regimented, and rules and the things that have to go right in order for an aircraft carrier to work are huge. But then on top of the aircraft carrier, there are these fighter jets, and you put crazy people on top of a jet engine and have them fly around and do all sorts of wild things that are life and death and totally chaotic. And the interplay between those systems mirrors, in my mind, a lot of the interplay between the ER and in some cases the rest of the hospital, right? The hospital, the system as a whole is regimented, and especially in modern systems really works within a giant box as like a flow chart of this goes here and this goes here and how much do you put it on this side to get out this stuff over here. But then at the same time you have this unpredictable face of the problem, right? Which is you never know what's going to show up, you never know when it's going to be there, you have no idea how serious it's going to be, and it has to be ready at any time. And so you have to have within your regimented system this totally chaotic force that's able to be like, sure, put me on in the middle of the night with no resources. I don't know, I'll figure out what happens and see how I can solve all these problems. And you want to shut down the CT scanner every night? No problem, we'll figure it out. It's cool, let's go do this thing. And there's you guys ever read Alan Watts? it is Zen philosopher. He's got this piece called Beat Zen, Square Zen, and Zen. And he sort of talks about the false duality about being either a beat or a square, right? You have to either be totally a product of the system and the man, or a complete outsider, free form, freewheeling everything. And that, like a lot of things, like the reality is more complicated and somewhere in between. And that to function well in this system, you must be chaotic, but you must interface with a square system, or a square system must be able to tolerate and interface with us crazies who are floating around on the outside of it. And that also probably describes Brown in a lot of ways. But separate from that, I think that tension is super powerful when it works, super destructive when it doesn't. And when we all reconnected a few weeks ago at this workshop on clinical AI, like I think that's the tension that I was seeing in that space as well, right? There are the standard systems of how things are supposed to work, how businesses work, how VC works, how whatever works. And then there's like the chaotic forms that are emerging as people try to solve problems. And you're marrying this tension between creative chaos and structured systems that enable rapid movement. I don't have a question to finish that tirade off with, but I'm curious what you all think about that. And has that mirrored your experience, or what's wrong with that idea?
It certainly resonates with my in the entrepreneur space, and also as a musician. There is always that tension of expansive creativity, unknowing, chaos. Might describe that, and also the foundational elements that allow systems to run and run well. I think where you run into trouble is when you have a massive imbalance of one over another. And especially when there is a misalignment for any given moment. So for example, you are relying on a system that might be many years old that was really designed for a different purpose, but the environment has changed, the landscape has changed, the needs have changed. So you're relying on a system that, while sure it works, it's not necessarily the most appropriate system for this new changing setting, and vice versa. When I started my company with my co-founder, who's also a family physician who also worked in emergency medicine for many years, our strengths were that we were able to function in chaos and be creative and meet the moment. And not while that in the initial phase of starting a company and building a team are necessary skills, they're not the skills that are ultimately going to get you from 1 to 10 or allow you to scale or allow you to build successful teams. That tension is important, but also the balance and the moment, and where one takes over really depends on the moment. And I think being able to not only balance that tension, but being open to shifting that balance to meet the moment.
Yeah, that's fascinating that there are times, I guess, as a very tactical example of that, right? I think we see that a lot in the ER when we've gone through the very initial phase of resuscitation and now we have a critical care patient, right? And so now we've gone from a mode where somebody comes in and they're just thinking about cases I've seen recently, right? They're super sick with CHF or whatever, and we end up intubating them for whatever reason. And so we've gone through the initial phase of we don't know, we're not sure, we're responding from chaos, we've intubated them. Now we're in a system that's more control heavy, and we're behaving to some degree more like intensive care, and we're thinking like intensive care. We're thinking about regimenting and titration and small changes and looking at the system and learning it that way. And to the extent that you can move your mindset and your skills from ER towards critical care in that moment, the patient really benefits from your team being able to think in that alternate mode. And then the next person comes in and they're stabbed and you got to go back to the other more chaotic mode. And the tuning of that, Mena, to your point about being a musician, right? I feel like you're like tuning the instrument back and forth and being able to create these different sounds out of it. But to have a system that's capable of doing that is really interesting to me, right? And Elvina, maybe that's going to become a question for you here as you've managed ERs and you've worked on bringing people into the system. and deploying teams against different problem sets. Like, how conscious are you of that? Are you assigning people to different roles based on their ability to switch gears? Excuse me. Or like, how does that play into your arc as you've moved from like coal face to managing the problem?
Yeah, that's a good question. It's the requirements and like I said, it's just guidelines are there for a reason, right? And usually they're set from hospital administration or regulatory, right? They're there and you can't change them, right? So it's like in some ways you're stuck with a constraint every day, whatever constraint it is, whether or not it makes sense, right? And to answer your question, I think we're all aware of the constraints, and it's what happens in the ER is you have to figure out how to work with and around and above and under the constraint, right? And I always think about the waiting room as the perfect example of this. There's this endless flow of people coming in. You have this insane waiting room of people. Sometimes we've had like 100 people in the waiting room before, and they're waiting 16 hours, and there's just a handful of people trying to manage that entire waiting room, making sure nobody's dying. At the same time, in our back door, we're a trauma center, there's just endless people coming in, right? And you're just,
Totally.
it's like this crazy thing of expecting a handful of people to decide whether or not you're sick enough to get the one open bed that is either going to be given to one person in the waiting room who's been waiting forever, or some trauma that's about to come in, and then you have to force a trauma that's in the trauma bay out of the trauma bay to make room, right? Like it's working around that constraint of people, or in California, we have our 1-to-4 ratios, right? Or like 1-to-2, they're critical. Having to figure out, okay, how do we just make it work so that nobody dies, right? And like, or nobody gets sicker, or like, what are we doing that is not necessarily on paper going to show that, yeah, there are nurses that are like, we're like managing people in the hallways, in the waiting room, like trying to figure out how do we just keep them going and not wanting to like rip our heads off because we're making them, nobody feels good keeping someone in the waiting room for that long, right? Or like some 80-year-old grandma that comes in for a stomach ache who you're just like, I know you're in a ton of pain. I have nowhere to put you, and I'm going to do what I can. And whatever the rules are given to me to be able to help you while you're in the waiting room. And what can I do to get you out of the waiting room to do more? Even though it's like we're dancing around rules here that we have to abide by, but it's never going to work, right? And so it's just, what do we do to make it work so that I can care for you because you're here looking for care, and that my staff are not going to get in a ton of trouble just because rules are gray, and or my nurses, they need to feel safe, right? That they can do their practice and like nothing's going to happen. Or it's just this, I don't know. It is this like, it's almost like how do I phrase this? It's almost like this unknown chaos in the chaos that's happening because we don't talk about it, right? We do it. We figure out a way to make it work because we have to, not because we even want to, because if we stopped and said, okay, we're just going to do it the way it's in the books and how we're supposed to do it, the whole thing would blow up. And so I think it's like this unspoken thing that we do in the emergency medicine trade of just figure out a way to make it work. And that's it.
That's so true. And that I'm sure all of us could sit down and tell stories of the noble aspect of that, and also the horror of that, of the choices that you have to make with people's lives to satisfy a system. And I think that we were talking earlier about going into emergency medicine as this adrenaline junkie, amazing, loving chaos kind of facet of it. But there also is this inherent sense of vulnerability and imperfection, right? And knowing that you are not the biggest mover into this system, right? You're not in control most of the time. And instead, what you have is the ability to, from the Stoic standpoint, lay the hand of cards you're dealt with love and like try to make something good happen with what you have. And I think that's a challenge to balance that optimism and joy and wanting to build things that are better for people with the understanding that this is the system that we have inherited and we have to work with it. Because if we stop working with it, people suffer and die. And I guess I'd love to steer us into that as like one of the last things we talk about in this is like, how does that tension work when you are intersecting with people who want to make a difference, who want to make something better, They're entrepreneurs, they're inventors, they're whatever. They want to build something new and amazing. They're so excited about the potential, but they haven't spent time cooking in the fire of seeing the reality on the ground. Because I think that's one of the things that the three of us really, rebonded about the other day, right? The difference between I'm so excited, I'm so passionate, which is so true, but also there's all these times when grandmas sit in the waiting room for 16 hours in terrible pain. And you have to handle both ends of that stick. So how do you balance that? How do you build things that are amazing, but also tempered in reality?
I think that's the hard part, right? I think that's to me, I think that there are a ton of amazing entrepreneurs out there that have ideas. Some great, some not so great, but only not so great because of exactly what you said, which is there's this missing angle of, in theory, this idea would be fantastic, right? You're going to change the way we do these workflows. But in reality, and I think it goes back to having a structured environment, sometimes those workflows exist for a reason, right? And it's not necessarily that workflows always kind of just show up out of nowhere. Someone at some point had taken the time to build this structure in there to help create this, to help manage the chaos a little. And so when you then throw in a new wrench into that workflow, you might think that it just so easily slides right in. But in reality, you're now breaking that workflow that took years to build. And you're just thinking that they're just going to do it, where you're like, no. I think what's hard is that healthcare providers, we are really challenging people to work with when it comes to adopting change, right? Because for us, it's also this idea, it's also like a learned behavior, right? The minute you get into your work and you've done it for a long time, it's like, you don't even think about it. You're just like, this is what I do. Boom, to get from point A to point B to point C, right? It's not like, now you're asking me to throw in something that I have taken months or years to learn, to normalize in my brain. And now you're asking me to change it up, right? And whether or not it's going to improve my outcomes, you have yet to prove to me that will actually work. And I need to understand that it's worth adopting your new thing because it's going to improve my outcomes, right? We talked in the beginning about measuring things. If you can't prove to me that it's actually going to improve my life because it's going to improve my patient's life, because it's that great of a solution, there's no way that it's going to be worth just breaking this entire system that I have taken years to learn and perfect. I think there's just like this.
Yeah.
You got to take a minute to step back and just think about why people are doing things the way that they're doing before you decide you're going to shake it up.
To your question, Dan, about how do you build something great while still considering reality? And I would turn that around and say, in order to build something great, you have to begin with a foundation and reality. I think you have to have a bit vision, imagination, and amazing team, and really deeply listen. But I think that's where we start to run into problems. And Lena, you described it, that gap in trust, in engagement, because a technology or a change in a workflow is so far from the existing reality that it either just never gets adopted, or it does, and there's so much friction, then it eventually gets left to the wayside, or in worst case scenario, it leads to unintended bad consequences, which both breaks the reality and doesn't achieve the goals of the innovation in the first place. I think to build something truly great, you have to be grounded in the present moment. And I don't think that being grounded in reality in the present moment, truly listening to people in communities, in hospitals, in clinics, I don't think that being a visionary those two things are mutually exclusive. I think actually the most successful companies, entrepreneurs, innovations, transformations of a workflow that lead to positive, measurable healthcare outcomes hold both an imagination and a creativity that can go beyond the existing reality while meeting the existing reality in the moment to start to shift things towards a direction and while building trust and engagement along the way. It's not a adversarial, hey, I'm coming in with this idea or this technology or this workflow, but it's, hey, let's let me understand, let me understand what you're experiencing, what matters to you, and work together to achieve a positive outcome for patients. Because I truly believe and that most people go into healthcare because they want to see good things for people and they want to see better results and
Totally.
I really don't think most, regardless of kind of the current state of affairs of health in the United States, I think most people go into medicine, become clinicians or work within the health system out of some desire for a positive social benefit in health. So I think getting back to that foundation and alignment and bridging that imagination, building something great starts with being actually very much grounded and rooted. They're not.
I love that. I love the balance between looking at the reality around you, but also being able to envision something different in the future around that. And to loop us back to something we talked about at the beginning about how the people around us alter what we see as the possible, the surface of possible, right? So I think there's a responsibility as some of the gray-haired people these days, not to include you two in that, but certainly me, right? But that I can hold the reality, but I can also imagine it getting better. And I can proactively talk about it and do things and change things. And there's this like small dumb story I like to tell sometimes about some shift where nothing was going right. And it was just all the system was breaking. Everything was terrible. The patients were super sick. We didn't have any beds. Everything was just a nightmare. And there was this door that every time it closed, it would be this horrifying shrieking, like squeaky sound. And as part of our shift in the resuscitation bay, we got WD-40 and fixed that hinge. And it was just like this moment of, I want to be part of a team that believes that things can get better, that understands the reality. I cannot fix this. I can't fix that. I can't fix that. But I want to be part of a team that believes we can do better. And I think if we start from that and hold that space, then that gets us towards what y'all are both describing, which is this vision of, I am grounded in what's here and I see what's possible. And I'm not trying to design some crazy thing out in space. I'm trying to design something that starts here and works here, but that does take us a step forward. I guess as an open question, if we could go back in time and tell ourselves this back in 2004, 2005, when we were at Brown, like, how do you tell somebody that, right? How do you harness that energy of wanting to change things without putting them through the same loop that we've been through? I don't know that there's an easy answer to that, but
I think what I would say is that, like, not just acknowledging the constraints, but really recognizing and understanding why they exist is going to be just freeing in a lot of ways, rather than fighting them. Kind of what you both had mentioned is, let's just work with it and then see if there are small ways to make those constraints better, rather than trying to change the entire system as a whole. Because then the constraints, as they change, as you improve them, the rest of the system technically should follow, right? I don't know, but it just depends on, I think it's a lot of times, I think people will try to innovate in the space and just think, like, constraints are there, let's just blow them up and we could do it better, different, right? And
reimagining healthcare. Yeah, totally.
Yeah, like I've totally been there, done that. And what I have learned through the years is, you can't just do that, because there are so many huge structures in place and so many unwritten workflows. You talked about the written workflow. There are all these unwritten workarounds that people have created to make their lives better within the system we have to work in, right? And so it also goes down to that, which is, if you know you're going to break this workflow for someone, you're probably breaking 10 others that you didn't even know about. And you wouldn't know about them unless you ask that person, what happened if this doesn't work? What do you do? And they're like, oh, I do X, Y, and Z. And you're like, oh, okay, that's a whole new thing. Right. And so I think if there was one thing I would have to really tell these entrepreneurs as they're trying to build in healthcare, is really understand not just what the constraints are, but why they're there, because that will unravel so many other things that people are doing. And also, how do people work around those constraints? And that will just completely change your perspective on what you're building, why you're building, and how you would implement it with clinicians.
It's awesome. Yeah, it's super smart.
Have you heard this author, David Epstein? He wrote this book called Range, one of my favorites. He just released a new book, so I'm going to plug something that I haven't even mentioned. But the title and the description is, it just so what you're describing, Elvina, inside the box, how constraints make us better. And this idea that the boundaries and rules and limits actually stimulate creativity and innovation, because if you have just total freedom, that leads to familiar patterns, even with life. But having some constraints actually leads to creativity and breakthroughs. I'm like, this is on my next book to read.
Nice.
I just want to follow up with what Elvina said, because I think it's so beautifully put that, meeting people where they are and understanding what the constraints are, kind of turning that around. They're there for, these things emerged. There's a story behind this, and they emerged for a reason. And there's things beyond what even is in the algorithm, beyond what's in that really dictate a lot of behaviors. And you won't get insight if you don't take the time to ask, listen, and really listen, which oftentimes means building trust in order to get that data, that insight. If I was talking to my Mena as a undergrad at Brown, what I would tell her is, on this topic of constraints, is that this is a starting point. This is not and to approach this as the constraints and existing systems as an opportunity. And I think that mindset of starting points in this, if we imagine, here we are, 2026, the world looked very different just 5 years ago, right? So we're living in a time that is already, because of AI, it's a forcing function to have to reimagine our workflows in every sector of society, right? Nobody's immune to this. And where the opportunity is, hey, this is a starting point. This is a new starting point, not an end point. This bringing in a new system, a new workflow, a new technology is, don't take it as okay, it's here and we're done. It's actually not. This is a new starting point that's allowing us to ask new questions, not just arrive at an answer and that's it.
Y'all, this has been awesome. And I'm so grateful for the two of you for all of your insight and for getting to reconnect with you and to dig into this. I want to give you the chance to issue a challenge to people on the way out, right? We end every episode with some challenge. So for folks listening to this, what do you want them to do or try or think about when they finish this podcast? And to stall for you briefly, I will give our normal disclaimer, which is that nothing we do on this podcast is medical advice. All of our opinions are our own and not anybody that we work for or with. We're just out here in the universe trying to make it better. So what do you want to challenge folks with?
I think every time you come up with a frustrating situation or you meet with a frustrating situation, you actually ask why. Why is it this way? Why do we have to do it this way? Or why is this person even in this situation? Because I feel like that's very standard startup advice, but it's really asking why, right? Why is we're really deeply understanding, rather than just accepting the constraint, right? Understanding what has led up to this point, to the point where everybody in the situation is frustrated. The provider, the patient, the family. And this happens a lot in healthcare. And so I think that it's just deeply understanding why the system is set up this way, not just that you're pissed about it and that it's annoying, but really looking into, why is insurance the way it is? Or why is reimbursement the way it is? Why do we have CPT billing codes? Why do we have this and that, right? I think the deeper you get into it, it's really, to me, it's been interesting because I am very curious about these things. And so, but the deeper you get into it, the more you'll understand also historically what has happened and why these things were put into place. And it's not always a bad thing. It's oftentimes things have evolved, maybe not necessarily the way it was intended to be when it was first into place. But when you actually historically read about why did this happen or why did we end up building a system like this, it answers a lot of questions and it actually is very freeing because then again, it's like learning about that constraint and then figuring out, okay, how do I build from here rather than break it and build it.
I love that. And I think it's worth highlighting from that you're not asking why from a place of anger or bitterness. Why is this happening to me? It's, even though it might feel like that sometimes in the ER, right? But instead, it's really a curiosity, how fascinatingly weird that this is shaped like this. What must have been true for this to be built this way? And that is, man, that's such a superpower. That's so cool. Mena, what do you got?
I will say that check your hubris at the door and embrace being a learner again. Embrace the not knowing. And when I think about us as in our early 20s, college, graduating, that spirit of learning and that it was infused in the time in our lives. Right? We're not supposed to have everything figured out. And somehow along the way, particularly in medicine, you are put in this place where you're supposed to suddenly know everything. That where I don't know is not something that is, I think, infused in the culture is something appropriate to say. I don't know, but let me find out. And we're all in this time there's so much unpredictability. I think if we don't embrace the being new learners again, if we show up in this moment with kind of this hubris of we are the experts, I know and we stay in that narrow lane, that we miss the opportunity to truly meet the moment and create something truly amazing on the other side. So that's what I would say is check the hubris and embrace being a learner again. There's a lot of freedom in it.
Amazing. Obviously, these challenges go hand in hand, right? To have that ability to learn and that desire to learn is so crucial to asking that why. And awesome. Y'all are amazing. Elvina, Mena, thank you so much for joining the podcast, and thank you for what you do.
Yeah, thanks. That was fun. Appreciate it.
Thank you.